Okay, thank you very much. So as Miguel said, I did transition from private practice in Canada to academic practice in Israel, and I'll be presenting my experience with Zen 45 microfistula. It's a continuation, in a way, of Dr. Pinchuk's lecture. These are my financial disclosures. I do work with other companies, including Aquasis, which makes the Zen, dealing with minimally invasive or microinvasive glaucoma surgery. So if in the past our classical treatment paradigm began with topical treatment, drops, and getting to maximal tolerated medical therapy, then moving on to laser trabeculoplasty, in the past more ALT, and these days more selective laser trabeculoplasty, only then going into filtration surgery. Out with the old and in with the new, and the future is actually here, whereby we do start with medical therapy. On occasion, we will start with laser trabeculoplasty, with laser surgery rather than drops. Only then would we move either to maximal tolerated medical therapy, or that's where minimally invasive glaucoma surgery comes in before the more invasive procedures. In 2012, in Current Opinion of Ophthalmology, Ike Ahmed and Hadi Saheb put together a brilliant review introducing minimally invasive glaucoma surgery. The characteristics of minimally invasive glaucoma surgery would be an Ab-Interno microincision. So the incision for the procedure has to be from within the eye. It has to cause minimal trauma to tissue, allow a future bleb procedure, have both minimal risk and a high safety profile, and a rapid recovery, one that is similar to cataract surgery. The Aquasis Zen implant was developed by Aquasis, is a soft and permanent microinvasive ab-interno subconjunctival implant. It offers surgical treatment for glaucoma. The material and design mitigate traditional implant issues, which are non-inflammatory and non-migrating. It is a permanent collagen non-migrating gel implant about the size of a human hair, not my hair in that case, soft, compressible, and tissue conforming, which reduces IOP through the clinically understood subconjunctival drainage pathway. The idea of the Zen implant is that it will allow all surgeons to implant the device. The future will be that all stages of glaucoma may use the Zen Aquasis implant. It is mounted on and preloaded on a disposable IOL-centric injector. Gold standard mechanism of action, yet it is minimally invasive. It bypasses all potential outflow obstructions and spares conjunctiva for future surgery, and has been shown to be successful in mild through advanced glaucoma. The Zen implant is a hydrophilic cylindrical implant of porcine gelatin cross-linked with glutaraldehyde to become permanent. The material has an extensive track record for medical use. It hydrates and swells and creates a soft, non-migrating, non-inflammatory drainage channel that is tissue conforming. It is 6 millimeters long with a targeted IOP design via the Poisson lobe. So where does the Zen implant come into our surgical armamentarium? So I will not discuss the Ab-Externo procedures, which we are very familiar with in glaucoma, being trabeculectomy and aqueous tube shunts, the less invasive canaloplasty and viscocanelostomy, and the endocyclophotocoagulation. I will talk on the subconjunctival space in terms of Ab-Interno, which is where the Zen implant comes in. Prior to surgery, naturally, and like filtration surgery like trabeculectomy, we do require mitomycin C. I can tell you that in the initial stages of this Zen implant, we did not use mitomycin, but as in filtration surgery or as in trabeculectomy, we do need antifibrotics. So the first stage of surgery can either be in the waiting area, whereby we pre-inject mitomycin into the subconjunctivally. One moment. So basically using a 30 gauge, about concentration depends from 0.2 to 0.4% of mitomycin, and we create a small bleb at the incision or the anticipated exit point of the aqueous. Another option is actually injecting the mitomycin intraoperatively, and this is a preferred approach whereby we try and inject the mitomycin further back from the limbus and having the injection site pretty far back to prevent leaks. So just an illustration of what the procedure looks like. So basically we prepare a very small side port incision to allow the 27 gauge needle to be inserted, going 180 degrees from the introduction site to the contralateral angle. The 27 gauge needle goes transsclerally, subconjunctivally, and while the implant is injected subconjunctivally, the needle is retracted from the sclera, whereby leaving a site within the angle, away from cornea and iris, and the trailing part within the subconjunctiva. Now for the study design. The study was a prospective, non-randomized, IRB-approved studies based in 3 sites in 3 continents. The Zen 45 implant was injected subconjunctivally along with mitomycin C, and cataract surgery was an option alongside the procedure. Inclusion criteria were basically open-angle glaucomas with mobile conjunctiva where the tip of the Zen implant was to be present. IOPs had to be between 18 and 35. Exclusion criteria are listed below. We characterized complete success as having IOP between 5 and 18 without medication, and qualified success as having an IOP between 5 and 18, which allowed medication. Failure criteria are also listed below. We had 68, now more, but I'll be reporting on our first 68 patients. The mean age was 61, same amount of male and female, and due to the nature of the countries where the studies were done, most of the patients were Hispanic. Most of the patients were in fact primary open-angle glaucoma. 10% had trabeculectomy with mitomycin done prior to the Zen Aquasis implant, and 2 had tube shunts placed prior. When we compare the two groups, those that had implant only versus those that had the combined implant and cataract surgery, the only significance was that IOP was different between the two groups. Now looking at the results, preoperatively, the IOP, the mean IOP of both groups was 22.3. And if we look at the follow-up, which is at 12 months for my presentation, we reached an IOP of lower teens, which is around 13. If we look at the lower graph depicting the number of medication or drop classes, we started with 3 drop classes and toward the end reached a significant decline of 1 drop. Looking at our Kaplan-Meier survival curves, when we consider our complete success, we see that it is fairly good and pretty excellent for the qualified success. Something that is very painful to talk about, complications in glaucoma surgery, but not in this case. So we can see no blood-related complications, and this is, granted, it is so far a 1-year result. 1 patient required additional surgery. We did have 1 patient that had tube erosion, 1 having a flat anterior chamber requiring anterior chamber reformation. We did have a few cases where we needed to needle the blebs in order to improve flow. No hypotony in this cohort and no wound leaks. Procedures that have been done worldwide today have reached approximately 700 cases with over 60 surgeons. The procedure is was CE-marked in 2011 and ID approved for investigational use in the United States, and 2 clinical trials are currently underway. It's expected to be approved within the next year or 2. I want to show you the beautiful pictures of what the device looks like in the eye. So over here we have a gonioscopic view of where or how the implant looks within the angle. I hope it is clear. We have a very light colored iris, and we see that it is fairly distant from iris, but you can for sure depict that it is very far from the endothelium. Over here, we can see a fairly mild white conjunctiva, so we don't see any reaction around the implant, and a fairly nice diffuse and low-lying bleb. Over here, you can see an anterior segment OCT of what the implant looks like via cross-section. So basically, it is lying on iris over here, going through the sclera and exiting in the subconjunctival space, and you can see that it is a fairly low-lying bleb. Now, getting close to the end, this is glaucoma surgery made ridiculously simple. So I will show you the surgical procedure itself. It is fairly quick and easy, so don't blink because you will miss it. So, entering through a side port incision, going on to the contralateral angle, no gonio view needed, using another incision to stabilize the eye, introducing the 27 gauge through the sclera until we see it subconjunctivally. Then we actually torque and twist the injector a bit and introduce the implant subconjunctivally. At the same time, the sharp needle will actually retract automatically. And this is basically the end of the procedure. So the Zen implant, in comparison to a trabeculectomy, does have effective IOP lowering. It creates a low-lying and diffuse bleb with access Ab-Interno. It lies deep in the intratenon tissue and carries low risk for infection. In conclusion, the Aquisys Zen implant is focused on site-preserving IOP reduction. It utilizes the global gold standard surgical outflow pathway, bypassing all potential outflow obstructions, traditional IOP reduction via a minimally invasive procedure. It is successful in both early and late stages of glaucoma and allows a broad range of surgeons to apply it. We do see the early evidence consistent with IOP and medication reduction over 12 months. So far to date, over 700 Zen Gen implants have been implanted by over 70 surgeons worldwide, and more follow-up is naturally needed with multiple international studies. Thank you very much.
Any question?
Yes, Dr. Pinchuk.
Very nice talk.
Thank you.
How do you get around in the United States the injection of mitomycin C?
So these studies,
Oh, I'm sorry.
these studies or the results have not been in the United States. I know that using mitosol has been helpful since it is possible and now indicated in glaucoma surgery.
Yeah. Well, we use mitosol too, but it has to be applied with sponges. It can't be injected.
Okay, so the injected pictures were
outside the country.
You were outside of the United States.
Thanks.
If you are talking about to make a stunt outside, so this you are talking about unconventional pathway, right? You are making an unconventional, and unconventional pathway means 10% only that goes through that way. We are talking about 360 degree, and that is 90% outflow goes through that conventional pathway. How do you accommodate this kind of things?
So basically, we are bypassing the conventional pathway. Basically, we're creating a low-risk trabeculectomy because we are bypassing all of the natural resistance that is present, for example, in the trabecular meshwork. So the implant bypasses the conventional outflow facility and then creates an alternative, which is practically towards a trabeculectomy. We're not getting the IOPs of a trabeculectomy. This is part of what minimally invasive glaucoma surgery offers. So on the one hand, it does offer the safety of minimally invasive, but it is a minimally effective procedure in a way. We do not yield a IOP of 10 or single digits as trabeculectomy. Typically, the IOPs would be in the mid-teens to 13, 14.
What is the flow rate? Have you measured the flow rate per minute?
I cannot tell you exact results of the flow rate, but I can tell you that with a 6 millimeter length and our 45 millimeter diameter, we do reach an IOP which is typically in the mid-teens without hypotony.
Thank you. Thanks.
There have been trials to implant more than one. It is not. It is not. Good question.
Excuse me, does the tubing swell at all in vivo?
It swells a bit when it is inserted into the eye. That's how it conforms and stays in place. The lumen, though, stays at its 45 microns of diameter.
And after swell, does the mechanical strength reduce or?
Basically, after it swells, or basically after it's hydrated, it becomes softer, so as not to erode the conjunctiva.
Nir, the last question from a surgeon point of view.
Yep.
I look at the procedure, it's look very simple, but you didn't use any gonio lens. How can you see the tip of the valve?
So you see the tip typically by, after you introduce it into the angle, subconjunctivally, you will see that...
You see the subconjunctival part, but when you use a microscope, because there is not a long tube like the previous, I can see the tip with the normal. Do you use normally gonio lens or by the experience?
So some surgeons initially start by using a gonio lens just to know where and what angle to hold
because
the inserter.
I was looking, for example, my first procedure. I will use a gonio lens at all.
So the company wants us not to use a gonio lens. Some surgeons that do have extensive angle surgery experience don't use it. Others that actually do have extensive experience would like to know where the tip is going. So it is definitely an option, and you do have the second hand. So we did see that we have our other hand, our fellow hand, will assist to stabilize the eye. At the same time, you can actually use a gonio lens to see where the implant is going.
Have you experienced any case of too deep penetration of the tip? So,
in case of
deeper,
longer tract, basically, it is possible not to get too much of the tip subconjunctivally. It has not happened to us. So you either get a shorter end within the anterior chamber, which is still fine because you get.
It's so simple to re-inject. Just take a forceps and.
It's not easy to re-inject. So if you're
just to push up, if you go deeper,
it's going to be once it's hydrated, it's going to be too flexible.
Okay.
So if you're not happy with the first implant, you just implant a second one.
Okay. Thank you.